Our OSSU Research Day, and the next session on our program is a second series of short presentations from those research teams who received and completed OSSU Empower projects. And as I mentioned this morning, the Empower project has just came out with another call, our sixth Empower project call for proposals, and the information is available on OSSU's website. And that again is ossu.ca. So for the moderator for this session is Miss Annette McKinnon, who is currently a member of OSSU's Patient Partner Working Group and a member of Steering Committee of the Canadian Arthritis Patient Alliance, or CAPA, the Sjogren's Canada, and the Arthritis Patient Advisory Board of Arthritis Research Canada. She's a founding member of the Patient Advisors Network, a community of practice for patient and family caregiver advisors. And Annette has had a long, dedicated history of supporting health and health services research. Annette, over to you.
Thanks very much, Dean. And I'd like to say good afternoon to everybody and welcome to OSSU's Research Day, Engaging Multi-Stakeholders for Patient-Oriented Research, Wider Effects and Reach project, Lightning Round Session 2. The Empower project program provides end grant funding for a co-designed project that's in need of an infusion of money for the purpose of furthering dissemination, awareness, and implementation of an original project goal to move the project forward. Projects are selected by a committee of scientific reviewers and a committee of patient partner reviewers. The Patient Partner Review Committee provides the final shortlist and the recommendations to OSSU. In this afternoon's session, we have 11 teams presenting highlights from the outputs of their projects, focused on their policy brief. And I'm pleased to welcome our lightning round speakers to the virtual podium. Our first speaker is Catherine Yu from St. Michael's Hospital, who will be speaking about putting shared decision-making into practice with barriers and facilitators to scaling up the My Diabetes plan into primary care.
Thank you, Annette, for the introduction, and thank you to the funders for your enthusiasm into a very important step in knowledge translation. I'm pleased to present on behalf of my tremendous research team and patient partners the results of this project. So My Diabetes Plan, so starting in the left in the background, My Diabetes Plan is an evidence-based online interactive patient decision aid that helps with shared decision-making and goal setting. And in a randomized controlled trial of 10 sites in Ontario, we found that it reduced decisional conflict as well as patient assessment of chronic illness and improved patient assessment of chronic illness care. However, we know that e-health implementation failure rates are up to 70% globally. And following the RCT, I did do some interviews with patients and clinicians about their experiences, but realized that I needed to know the full story and it required more interprofessional stakeholder involvement. And so that was the purpose of this project. I needed to learn not just about what patients and clinicians thought, but actually what the full primary care context was. So administrative staff, executive directors and medical directors of the family health teams, IT personnel, as well as MOH decision makers. And so I talked with different stakeholders and got their inputs about the primary care and health system level context. Moving on to key findings and policy implications on the right, we used the normalized NPT theory to identify that we really needed to assess individual patient, individual level buy-in, both patient and clinic staff buy-in, as well as MOH stakeholder buy-in. And I'll focus on the right here with MOH stakeholder buy-in. With our interviews with MOH, we found that potential improvement in clinical outcomes and healthcare system navigations were potent sort of motivators for MOH to be engaged in implementation. And they suggested that next steps to scale up would be integrating into patient portals, connecting with Ontario health teams, and aligning with other key existing government priorities, such as ending hallway medicine, digital first for health. We also recognize, because healthcare is a complex system, that we also needed to consider organizational level and societal level facilitators and barriers. So from an organization level, so for example, family health teams, clinic integration dependent on alignment with philosophy of care, as well as pre-existing technologies and workflow. And from a societal level, we needed to ensure that it matched with political climate and trends in technology use by patients and clinicians. So that's the end of my time, and I look forward to the remainder of the presentations by my team members.
Thank you, Catherine. Next is a presentation by Manoj Lalu from the Ottawa Hospital Institute. His presentation is about the co-creation of a framework to engage patients in preclinical laboratory research.
Thank you very much, Annette, for that introduction. I'm presenting on behalf of our patient engagement in basic science team, and that's led by both myself and Dr. Dawn Richards. Dr. Richards is actually our lead patient partner on this program as well, too. So the issue that we're tackling is that patient engagement is highly prevalent and becoming entrenched in clinical research, as we've heard much about today. However, on the preclinical or basic science side, this has not been the case. And by preclinical, I'm really talking about laboratory-based research that is done on cells or animal models. And this is a particularly interesting problem because when you look at major funders like the Canadian Institutes for Health Research, the largest proportion of their funding actually goes towards basic biomedical research and not what we would consider sort of more patient-facing clinical research. So there's a big gap here, and it's one that we're trying to fill, first of all, by designing a framework for patient engagement in basic science or preclinical research. So in our policy brief that we've developed, and this is going to be targeted towards researchers, so basic science researchers and potential patient partners, we've outlined some issues we've identified in terms of potential challenges for patient engagement in basic science and some potential solutions. So first of all, starting at the left, we realize that at present, there's very few motivating factors potentially for patient engagement in basic science. So we're trying to raise the awareness of the value of engaging patients at this very early stage of research, which ultimately, hopefully downstream, would affect patients with lived experiences or particular conditions, and foster an inclusive environment and culture within laboratories, again, that is inclusive of patient partners. Secondly, we realize that there are not as many resources for or to guide patient engagement in preclinical research. So we're actually creating and sharing resources and templates that we hope that researchers and patient partners could use in terms of project timelines and budgets and how to actually engage each other within these research programs. Finally, we realize that in the preclinical space, again, that research is not directly patient-facing or clinically facing quite often. So the chasm between the researchers and patient partners might be a bit larger as they have differing perspectives, backgrounds, and bigger differences in the language that they use. So through our policy brief, we're suggesting that patient partners and researchers take time to develop partnerships, create a common ground in language, and identify shared goals for preclinical research. And we're really excited that we're going to be able to apply this in the new year, as we've been funded by both CIHR and Canada's Stem Cell Network to actually field test this framework with pairs of research groups and patient partners. Thanks for your time.
Thank you, Manoj. Next is Madison Foster from the Ottawa Hospital Institute on building a platform for meaningful patient partnership to accelerate the translation of promising new therapies from bench to bedside.
Great. Thank you so much for the kind introduction. I'm excited to be here today on behalf of our entire Getting Better Outcomes with Chimeric Antigen Receptor T-cell therapy team. which is led by Dr. Manoj, Lalu, and also inclusive of our patient partners, Terry, Stephanie, DJ, and Michelle. And so just to provide a little bit more context about our research project, we look to engage patients as partners in an early phase clinical trial. And this was both throughout the design and conduct of the trial, which led to a number of different patient engagement activities, including the co-development of visual consent aids for trial participants, which was an idea that came from patient partner members. And as well, a new grant idea for expanding this patient engagement approach to additional trials as well. Today, I wanted to share with you a little bit more about the policy brief that the team has worked on. So just a note that when we initially set out to draft this policy brief, our team had identified a systematic review that found that very few clinical trials report on engaging patients at this stage of research. And so we saw development of this policy brief as an opportunity to identify options to help encourage, promote, and improve patient engagement in early phase clinical trials. And upon team discussion, when we were deciding who to focus our policy brief on, we chose to focus on research funding agencies as we saw this stakeholder as being in an excellent position to have a real impact on research teams and patient partners, so those who are developing and conducting patient engagement programs. So just to tell you a little bit more about the options, we first proposed that research funding agencies could point researchers to existing resources on patient engagement, and this would hopefully help to address the challenge that research teams may have in identifying credible guidance, and they could provide this through their grant agency websites. Second, we proposed that research funding agencies could require researchers to include if and how they will involve patients in grant applications, and if they have previous patient engagement experience, as well go one step further to involve patient partners in providing feedback on these patient engagement plans and deciding which research grant applications are funded. And finally, our third option was to propose that research funding agencies require researcher training on equity, diversity, and inclusion for recruitment of patient partners to clinical trial patient engagement programs to help ensure that researchers are taking these considerations into account when planning patient engagement. And so just in terms of next steps for the policy brief, we do note that it was challenging to identify systematic review-based evidence for these options. And so as a next step, we would recommend further research being conducted to better support implementation of these options, as well as subsequent monitoring and evaluation to assess the impacts of these options and assess whether further strategies and resources may be required. So thank you so much for listening today.
Thank you, Madison. Yona Lunsky from CAMH is going to be presenting next on digital tools to improve healthcare communications for people with intellectual and developmental disabilities.
Thank you. So in our project, we really wanted to address the problem, which is that for people with developmental disabilities, their healthcare is definitely hampered when the communication with healthcare providers doesn't work the way it should. And so we were really looking at ways to work together, both with patients and with families, as well as staff who support them to have more patient-centered communication tools, which can not only help, I think, during that actual healthcare interaction, but in terms of preparation and then transition after that interaction. So the big lesson we learned, we used paper tools initially, and this was pre-COVID. Those could be really valuable to people with disabilities and to families, but having them more accessible to healthcare providers in today's environment, and especially once the pandemic hit virtually, is really important. So that embedding makes a huge difference when they're in the EMR itself. And also we learned that rather than just talk about tools and how they're valuable, embedding the tools into our education. So we're part of an ECHO learning program using case-based learning to explain both to healthcare providers, but also to patients and to families, by patients and families, how that kind of communication tool enhances care during a case makes a big difference. On the right side of the slide, we highlighted 4 lessons we learned around engagement with patients and families. One being that creative sort of individualized way of supporting patients and families if they really are going to be authentic members of the team. Especially if you have an intellectual disability, the way you learn might be different than the way someone else learns. And we really had to adapt our approach to help them, especially in the virtual environment. 2, those voices are really important, working with patients, families, but also with healthcare providers when we were doing our KT. And we needed to think about ways we could amplify the diverse expertise that people had in our group who were advisors, recognizing that our ideas about how, for example, they would be in a presentation or do their engagement might not be what they're most comfortable with and what they're strongest with. So one example was, instead of giving a talk with a script, being able to answer very specific questions that reminded the individual of what it was that they wanted to talk about in an interview style made a difference for one person. And finally, and this was so obvious during the pandemic, we need to have multiple voices, both from the patient and family perspective, to do this kind of work together, because it's a lot of pressure when you're one voice. You need diversity of different voices and strengthen those voices. And also when there are pressures in terms of lived experience and health, you can't be the only one at the table, because you need to be able to step back and have that flexibility. Thank you.
Thank you, Yona. Jennifer Walker from McMaster University and Carol Mulder from the Chiefs of Ontario will present now on the Ontario First Nations Aging Study, focusing on data, research, sovereignty, and action.
Thank you. So this Impact Award, this Empower Award, actually, we were building on a CIHR funded study that we called the First Nations Aging Study. And it was a partnership between academic researchers and the Chiefs of Ontario to answer questions about aging in First Nations in Ontario. And what we wanted to do in this part of the work was to learn how to improve the usefulness of First Nation research based on the uptake of that study. So we had done an accessible report and had shared the findings of that study at the First Nations Health Forum year after year during the study. So it was a study that was very attentive to OCAP principles, which are First Nations ownership, control, access, and possession, and was done in partnership, as I said, with Chiefs of Ontario and with the Knowledge Circle of other community members as well. But we also found early on in this work that very few people in First Nations communities had read the report. It had been used in some policy conversations, but communities had not read the report or used the findings yet. So what we sort of came to was that in First Nations research, we'd like to start talking about OCAP, including an action principle in First Nations research. And it has to do with that learning health system we were talking about this morning, I think. And that community engagement is a priority for patient-oriented research with First Nations. I'm going to let Carol talk about the impact.
Hi, thanks, Jennifer. The impact in terms of the Chiefs of Ontario was that we came up with 2 products to actually try to address the usefulness of the First Nation Aging Study, first of all, and then again with our goal to improve usefulness of First Nation research more generally. So the policy brief was developed that addressed a key finding of the First Nation Aging Study, which was about access to home care services. So that policy brief identified 3 actions that could be taken at different levels of the healthcare system, and that policy brief went to the health sector in Chiefs of Ontario to take further action. And so that was one piece that came out of this project. And the other piece was the knowledge to action framework, again, that emphasis on action, with the idea that we would now have a framework that could be shared with researchers looking to do First Nation research and with community engagement, so that we could increase the chance that the research would result in community level action. Thank you.
Thank you, Jennifer and Carol. Next to present is Ambreen Sayani from Women's College Hospital and Alice Maybee, patient partner, presenting on the MPACT project and increasing impact through equitable patient-oriented partnerships.
Thank you, Annette, for the introduction, and thank you to OSSU for the Empower Award. I think specifically for recognizing the fact that engaging with diverse voices is a challenge and that we do need innovative ways in order to build inclusive and equity-oriented partnerships. Elise, over to you for a quick.
So I've been a patient partner since 2011, and I'm often asked how to engage with people who are not like me, female, white, and older. Like Ambreen, I've been exploring the challenge of involving diverse perspectives in an authentic way. And this brought us together to co-initiate MPACT, the Equity Mobilizing Partnerships in Community. If we look at the arrow, we started at the bottom there by listening and learning from various stakeholders, including administrators and funders and others. But we spent most of our time listening and learning from community. We built our existing relationships with people that we knew who had diverse lived experiences, and we came together to form a core community that helped attract like-minded people. So the foundation, as you see in the bottom blue there, is the relationships. And the foundation was built on these trusted relationships nurtured over time. The group was clear they wanted to focus on health equity. We co-designed with our community how we would do this. We formed the MPACT community to exist separately from any single project so that we could service multiple projects. And we flipped the paradigm by forming a community table where the healthcare partners come to us to learn better how to incorporate health equity into their work. Over to you, Ambreen.
In essence, projects have been unable to tackle health inequities effectively because A, they haven't taken social theories of health inequity into model design or considered issues of scale and spread. We were able to do both. We co-built and co-designed the community together with patient partners, how they wanted to come together, why they wanted to come together, what they wanted to do. We built out our skills so that lived experiences were informing a health equity assessment on projects that come to the table. In doing so, we have partnered across several hospitals across Ontario, published manuscripts, and done over 13 technical reports. I'll give it to you, Elise, to wrap up.
Yeah, so our community has grown to 15 strong with no attrition. We now have a full-scale deployment. We have consulted with many across policy, practice, and research from different organizations and areas, as Ambreen said, and we are continued to be sought after and are booked well into next year for our consultations. And thank you very much for listening.
Thank you, Ambreen and Elise. Beth Potter from the University of Ottawa and Maureen Smith, the patient partner who you saw this morning, will be the next to present on implementing a sustainable collection of core patient-oriented health outcomes for pediatric metabolic diseases and a multi-stakeholder workshop.
Great. Thank you very much for this opportunity. I'm presenting on behalf of our whole team and want to particularly acknowledge Maureen Smith, who co-led this work. So our Empower Award project was followed from a previous study funded by CIHR to develop core outcome sets, or COS, for children with rare inherited metabolic diseases, where a COS is an agreed list of outcomes that should be measured at a minimum in all research studies for a health condition. And so we followed established methods for COS development, which included conducting a systematic review to identify a long list of candidate outcomes based on what had been measured in previous studies, a multi-round Delphi consensus survey, whereby patients and family members, healthcare providers, and policy makers rated the importance of the outcomes to narrow down the list, and finally, a consensus workshop where these same groups came together to discuss and vote on the final COS. So this study had a comprehensive patient engagement strategy that was led by two patient partner investigators, Maureen Smith and Nicole Pallone. And the end of grant knowledge translation really for our project was focused then on reaching out to our broader research community, including patients and family members, healthcare providers, policymakers, and researchers. And we were interested in identifying their preferences and their perceptions about the barriers and facilitators to uptaking and implementing the core outcome set. And we were particularly interested in implementing the core outcome sets in new Canadian registries to support registry-based randomized trials. So it was a patient partner idea, Maureen's idea, to seek Empower funding for this, and 2 patient partners were among the lead applicants. So our Empower Award funded an in-person pre-COVID workshop where attendees were patients and family members, as well as healthcare providers and methodologists. And we focused on understanding perspectives about the feasibility of collecting the outcomes that were part of the outcome sets, as well as registry sustainability and processes around data sharing and consent. The patients and family members who took part had the opportunity to contribute to selecting outcome measurement instruments for the patient and family reported outcomes with training, and discussing whether and how they should be integrated into clinical care. And so with new funding, the insights from the workshop are currently being incorporated into our development of these registries and will support the design and implementation of registry-based randomized trials. And our new projects, also funded by the CIHR, are continuing our commitment to co-leadership and co-development with our patient partners. Thank you very much.
Thank you, Beth and Maureen. Jennifer Stinson from Sick Kids Hospital will present next on the project Partnering for Pain and Taking Action Together on Family Identified Priorities in Pediatric Chronic Pain.
Thank you, Annette. Good afternoon, everyone. I'm delighted to present on our OSSU Empowered project that was led by Dr. Katie Burney when she was a postdoc fellow in my lab, and our patient partners who you can see on the slide, Carly, Catherine, Justina, and Adam. So like others, our original project was funded by CIHR, where we set out with patient partners to identify the top 10 research priorities for pediatric chronic pain in Canada from the perspective of people with lived experience following the James Lind Alliance Priority Setting Partnership Framework. The OSSU grant enabled us to undertake knowledge mobilization of these findings to take them out to youth, families, healthcare professionals, decision makers, and researchers. One, to try and generate awareness and interest in the top 10 research priorities and our partnership processes. So we created a one-page infographic that was available in English and French. We created a brief video that talked about the process of coming to consensus of the top 10 priorities and what they were. With patient partners, we developed a patient journey map that really showed the impact of these top 10 priorities on the lived experience of young people with chronic pain. And I'm pleased to say that our video actually received 2 recognitions. We won the Pain Awareness Award from the Canadian Pain Society and also the CIHR IDSI Video Prize. Secondly, we co-facilitated some deliberate dialogues with various stakeholders, the Canadian Pain Society and the Ontario Chronic Pain Network. We also took these 10 top priorities and tried to integrate it into various other documents. One was the creation of an evidence and gap map, where you can clearly see what the top 10 priorities are and where the gaps are in research to help push researchers to try and prioritize those areas, and also to help with funding those areas. We also co-presented these top 10 priorities at various meetings with our patient partners at the Canadian Pain Society through Project ECHO and Children's Healthcare Canada. And I'm really pleased to say that these top 10 priorities made it into the Action Plan for Canada, which is the new strategy for pain care in Canada. And our 2 patient partners, you can see a picture of them on the video, were at a lobby day on Parliament Hill in April 2029. So the summary of this work really was that partnership with youth with chronic pain and parents led to a greater impact of our work. A focus on knowledge translation and patient partnership enabled our work just to move beyond knowledge sharing to actually result in behavior change and policy change. And by involving more than one patient partner, we are able to overcome challenges that people have talked about already, why it's so important to include multiple patient partners and from diverse backgrounds. Thank you.
Thank you, Jennifer. Tieghan Killakey presents next. Her project is about ensuring equity and inclusion in virtual care to support youth with chronic pain.
Great. Thank you so much, Annette. And I'm also thrilled to be here presenting on behalf of our co-leads, Dr. Stinson and Dr. Burney, as well as our quite large team of researchers, patient and family partners, and partner organizations as well. So as many of you are aware, the COVID pandemic led to a rapid pivot to virtual care across all areas of health, including for youth living with chronic pain. So in response to this, we conducted a rapid knowledge synthesis to identify recommendations for best practices for virtual care, specifically for youth living with pain and their families. Our review highlighted a range of recommendations related to leveraging and implementing virtual care, selecting the best platforms, as well as identifying limitations in virtual care. And these themes were all summarized in a one-page infographic available in English and French. However, in undertaking this review, we really recognized the lack of diverse populations in the included studies. And we know pain services and research disproportionately exclude individuals who are marginalized, despite being vulnerable to higher prevalence of chronic pain and less likely to be able to access virtual care. So the aim of our Empower project was to engage with diverse youth with chronic pain and their families to build on this review and ensure that the recommendations for best practices for virtual care were inclusive and equitable. So we engaged with Black youth with sickle cell disease, Indigenous youth with chronic pain, and youth with complex medical needs and their parents and caregivers in collaborative dialogue regarding these recommendations for virtual care. Our virtual collaborative dialogue sessions were held over Zoom. This was all COVID research from November 2020 to January 2021, and they were all co-facilitated and really led by our patient and family partners. The suggestions that were made during these roundtable discussions revealed additions to the best practices for virtual care that really weren't previously identified in our literature review. So based on this feedback from the sessions, we modified our infographic, and you can see a portion of the new infographic on the left side of the screen. And our findings have been shared in a variety of settings, especially with our partner organizations such as Complex Care for Kids Ontario and Child Bright. And our policy brief can be found on the Partnering for Pain website, as well as our publication, which can be accessed by scanning the QR code on the bottom left of the screen. So what's next? We know from our engagement sessions that COVID-19 resulted in delays in care and challenges pivoting to virtual care, and youth need access to individualized interventions to support their pain and mental health. So to address this, we've developed a virtual pain hub to empower youth living with chronic pain to engage with evidence-based interventions in a stepped manner. This is called the Power Over Pain portal, which was co-designed with a diverse group of youth living with chronic pain across Canada. And we'll be testing this portal for youth in the community and who are on pain clinic waitlists across Canada. And that QR code on the right brings you to a video that provides an overview of the portal if you're interested. And then finally, building on the findings from our collaborative engagement session, Katie Burney received a CIHR Catalyst grant to explore shared decision-making for in-person versus virtual care for youth living with chronic pain. And this idea for new research was really generated from the work done with our Empower Award. So I'll end it there. Thank you.
Thank you, Tieghan. Kerry Stewart is our next presenter. She's a patient partner working with Shelley Vanderhout from the University of Ottawa on the Understanding COVID-19 Among Children and Families project.
Hi, everyone. Yes, thank you for including me. I am presenting on behalf of the entire Target Kids team and all of our involved parents like myself. So in understanding the impacts of COVID-19 among children and families, the parent engagement in this cohort study, this study took place within Target Kids. That is a primary care-based cohort study of children, healthy children, that has been ongoing since 2008. Our patient engagement team, which we call PACT, or our parent and clinician team, like myself, started in 2018. Target Kids has enrolled over 12,000 children to date and routinely collects information about children's growth, development, lifestyle, and nutrition. The information is collected at regularly scheduled well-child visits to better understand child health. At the start of the COVID-19 pandemic, Target Kids launched a study of COVID-19 among children and families to explore the physical, mental, developmental, and social impacts of the pandemic among participants. Target Kids partnered with parents of the children to orient their research questions and methods around family values, priorities, and routines to broaden the diversity of participants and help share results with their communities. Through the pandemic, the PACT meetings, which were previously held in person, continued virtually, allowing and enabling the parent partners like myself to share input and feedback over email, Microsoft Teams, and Google Drive. The study impacts our research questions, survey tools, and outcomes reflected parents' perspectives and priorities. Parent partners provided letters of support for funding applications to support ongoing research, especially about new questions that arose as the pandemic evolved. Parent partners helped recruit to the study by encouraging peer children and families to enroll. The impacts are also that we helped families access and understand study findings through newsletters and meetings using an integrated knowledge translation approach. Parents helped design an infographic about findings from the COVID-19 study, which was shared with all participating families in Target Kids. Thank you.
Oh, you're muted, Annette.
Thank you, Kerry. And for our final presentation, Shelley Vanderhout will present her project on partnering with communities for children's COVID vaccinations.
Thanks so much, and thanks, Kerry, for presenting the first segment of this sort of two-parter that we've been given time for today. So another aspect of Target Kids research has focused on COVID-19 vaccination for children. So within the Target Kids cohort study that Kerry just described, we also conducted a qualitative study to understand more about parental decision-making around COVID-19 vaccines for children. So this involved conducting interviews with parents of children in the Target Kids study. And to help inform this vaccination study, as well as ongoing Target Kids research, we held a workshop with our parent and clinician team, which is comprised of about 15 parents, 1 patient engagement coordinator, and 5 researchers. The workshop was facilitated by an expert in equity, diversity, and inclusion, or EDI, at the University of Toronto, who spent time providing us with some foundational information about why EDI is important in child health research and in patient engagement, how members of diverse communities may view or experience health research, and how parents may be empowered in their own communities to think critically about disparities that may exist when it comes to accessing research and evidence-based health information, such as information about vaccination. The goal was to explore how we could ensure our research could include and be shared with families across diverse communities in Toronto. So in this workshop, parent partners shared barriers that families may face in engaging with research, such as concerns about privacy, trust in government, and uncertainty about the value of their participation. Parents also thought about ways that families from diverse backgrounds could be reached and included in our research, as well as in our parent engagement team, or PACT. And they thought of ideas such as building trusting relationships by attending local events, or identifying and working alongside key community members who could advocate for child health research, and particularly joining our study. Finally, our parent and clinician team was asked to think through ways that each member could share our COVID-19 research findings with their own communities. And we are collaborating with parents to develop infographics and other shareable materials to facilitate this. As a result of our workshop, we have been able to prioritize several approaches to broadening the diversity of our research participants and parent partners, as well as form small working groups of parent partners who are interested in focusing on EDI, as well as knowledge translation and community outreach within Target Kids. Thank you so much for the opportunity to share today.
Thank you, Shelley. It's been great to see and hear the amount of benefit the Empower Awards have created, and to actually see and hear the patient partners and the researchers presenting in person.
Great, thank you, Annette, and thank you to all presenters for keeping on time. So much so we actually have about 4 or 5 minutes left, and I was just going to ask maybe Dr. Lalu, Manoj, you're pushing the envelope in a very, very different sort of area in basic and biomedical research. And we tend to think of patient-oriented research or patient engagement in clinical, applied, or health services research. What has been the reception in that community?
Well, I think sometimes it's been a bit of a question mark because it's something that hasn't really been thought about, as we raised earlier. But on the other hand, once some of those initial connections have been made from research groups who have never had patient partners involved in their group before, and we connect them, it's actually been really exciting in some ways, and new ideas generated, and new directions for some of these research programs as well too. So and hopefully we're going to see more of that in the new year when we start to roll out our test pilots of our framework.
Okay, thank you. And Ambreen and Elise, not to put you on the spot, but the importance of diversity and equity in our patient partnerships is so vital. And it seems to me, and hearing from a couple others, that taking, rather than a project specific patient partner or partners, having sort of a panel or a committee or whatever name we give to it, may be a more promising way. Do you want to further comment on that?
You want to go first, Elise? Go ahead.
I was just going to say, I think it's really about community and about having a safe space and a place where you can develop relationships and relationships of trust. And that's the most important thing. Ambreen, do you want to add to it?
I think what a community table kind of structure allows you to do is put the theory and principles of EDI into practice, right? So what is that equity-oriented approach? Who should you be engaging with? Where do the principles of cultural safety actually, where does the rubber hit the ground when you're doing it in practice? How do you build accountability structures and prevent tokenism and maintain a long-term engagement that is not grant funded and episodic, but have those relationships that can feed into an inclusive and equitable system? So I think it's really about taking the theory into practice and then developing a model out of that.
Very good, thank you. And that actually presents a nice segue into our next topic, but I'd really like to thank Annette for moderating this rapid fire session, and all the presenters once again for their talks and keeping on time and giving us a nice slice of all the patient engagement activities that are taking part within the Empower Awards. So thank you very, very much.